Yeah, so we'll just wait until like it's 1 or 2 minutes past and then we'll start. Get everybody in. Okay. And I think we'll make a start. So welcome everyone. My name is Stephanie Garty. I'm co-editing the ePrescribing Masterclass for this month, for November, and we'll be doing it until July 2022. So I'm the new Chief Pharmaceutical Officer's Clinical Fellow at this year at NHSX. So welcome everyone for joining. So today our ePrescribing Masterclass is going to have a focus on antimicrobial stewardship as well as patient safety. So World Antimicrobial Awareness Week is from the 18th to the 24th of November. So we decided in collaboration with Kieran Hand to have a focus on antimicrobial stewardship. So we're going to hear from 2 new speakers this webinar, and our first speaker is going to be Graham Kirkpatrick, and he's going to be talking about e-prescribing and chemotherapy related issues and patient safety. And Graham Kirkpatrick, he's the head of patient safety and advice and guidance at NHS England and NHS Improvement, and I'll hand over to him to give our talk for today.
Thank you very much, Stephanie. Thank you, everybody. For those of you who have heard me speak on this masterclass in the past, I come here with problems. I don't come here with solutions. That's up to yourselves. So these are just issues that we have picked up as part of our review of patient safety incidents that we thought were worth sharing with you, that have an e-prescribing bent to them, and that you may want to go back to your base and consider how you may want to handle them in your own trusts. Next slide, please, Sarah. So just a bit of background for those of you who haven't heard me speak. One of the National Patient Safety Team's roles is to look at reported patient safety issues. I identify any that are new and under-recognized, and then try and develop advice and guidance to mitigate against those identified patient safety issues. Our advice and guidance can take a number of different forms. We can go back out through networks such as this, or through the medication safety officers. We can collaborate with our partners and work up some guidance with themselves, or we can issue a national patient safety alert. And like I said earlier, these sessions are intended to be thought-provoking and a bit of a challenge to you. They won't necessarily give you any of the solutions, I'm afraid. Next slide, please. So the first issue that I wanted just to pick up with you at this session relates to Rasburicase. So if you look on the left-hand side of that little box, that is the incident description that we have seen when we're doing our reviews. And this is about a patient who was prescribed methylpred to fight lymphoma because his kidney function was decreased. He was supposed to have Rasburicase, which is something that certain cancer patients get to avoid tumor lysis syndrome, and for various reasons they didn't get that Rasburicase. Condition deteriorated, ICU called to talk about dialysis, but he became too ill and unfortunately died 59 hours after his first dose. The additional information in the incident report was that the nurse gave the methylpred, says that the Rasburicase wasn't available on the ward, and it wasn't available the following day either. and they didn't really point out the critical nature of the omitted drug. So we've had a look into the national reporting and learning system to see if there were any similar issues. Some of the themes that we found was about omitted and delayed, as in this incident, some prescribing issues, stock availability issues. So the challenge back to yourselves is about how are supportive treatments for cancer patients prescribed? Are they done on the chemo EP system? Because sometimes you have a separate ePrescribing system for your chemotherapy. Is it done on the main ePMA system? Is it done on a separate paper chart? And we have identified that often patients are given their chemotherapy on a day ward, a chemo day ward, but if their treatment runs past, say, 5 o'clock and the day ward is closing, those patients may be sent to a base ward. And how does your ePMA system deal with that if it's been, if the Rasburicase has been prescribed on the chemo EP system, do the wards have access to that? So how can our ePMA systems support appropriate prescribing and administration of these supportive treatments? How can they warn about a critical nature of a medicine? Is there anything that tells the nurse this shouldn't be omitted? Phone on call to pharmacy if you don't have any on your wards. That sort of issue is the challenge back to you. Next slide, please. This incident describes a patient who had a breast cancer in her left breast back in 2006, received 6 cycles of an anthracycline containing chemo, and then 13 years later, she unfortunately developed right-sided breast cancer. And although the oncology consultant noted that she had previously had chemo, they went on to give her further anthracycline containing regimes. And this therefore meant that she had exceeded her lifetime dose. The coroner's conclusion was that she died from chemotherapy-induced heart failure. Again, the additional information which is pertinent is that oncology used the chemocare, or they now use the chemocare system. Back in 2006, it was on a paper charts, and in practice, they didn't have any way to reconcile those records. So again, how can chemotherapy ePMA systems, whether that's a separate system or a separate module, support the tracking of lifetime doses, especially if that chemo was given in another trust or on a paper chart? Is there any warning to check if you're giving anthracyclines what their previous dose was or what their previous lifetime dosing was? So again, that's the sort of the challenge that we're giving back to you based on these incidents that we've seen. Next slide, please. And I think the final example that I have for you is about Hep B reactivation. So a patient's Hep B antibodies weren't checked prior to the chemotherapy. Their Hep B was reactivated, and that meant the patient developed liver failure. The additional information says that the current ePMA system relies on individuals to check any virology results. There's no hard stop in their system to prevent rituximab and others that are involved to be prescribed if you don't have the HBV status. they in their report make a recommendation that a reminder should be added to the chemo systems. So again, our challenge back to you on the call is, do your systems have a hard stop to ensure that any relevant essential path results are available, recorded in the system to ensure safe prescribing? And although this is about Hep B, there may be other similar examples outside of chemotherapy that you may want to think about. And I just wanted to highlight, if you haven't seen the previous versions of the new, there will be a new set of standards for the safer use of EPMA systems in cancer therapies. I've seen the draft version of the update. I think it's just gone to the chemo board for ratification. So keep one eye out for that when it starts to come through your networks, through your contacts. Let my next slide, please, Sarah. I think is my last slide. So this was just a general thing about how involved are you as EPMA expert pharmacists in national patient safety alerts. These are just 3 examples of recently published national patient safety alerts that had some actions involved in them that may have involved changes to the EPMA system. So there was one about sodium nitrite and replacing all unlicensed sodium nitrite ampules with license. So were you involved in taking off the unlicensed ampules so they weren't available on your systems? And just as a very recent update to that one, the Royal College of Emergency Medicines and the National Poisons Unit have just published their updated antidote guidance, and actually sodium nitrate isn't a recommended antidote for cyanide poisoning, so you can further update your systems and take off sodium nitrate in totality, because it's I don't think there's any other use apart from cyanide poisoning. We issued one around liquefied phenol, and one of the specific actions was to amend ePrescribing system to ensure liquefied phenol 80% cannot be prescribed. The action complete date for that is the end of February, so you still have some time to work with your colleagues to ensure that gets actioned. And then finally, there was a medicine supply patient safety alert issued for varenicline, because it's no longer available until further notice. So what do you need to do on your systems to make sure that people aren't trying to prescribe it whilst it's unavailable? And just finally, as I say, patient safety is a team game. It's really important that yourselves as the e-prescribing experts are working very closely with your medication safety officers and your patient safety specialists in your trusts to ensure that the response to patient safety issues include any changes you may wish to make or you're mandated to make to your EPMA systems. And to try and build that, we are hoping in February next year to have a joint MSO ePrescribing Masterclass to try and get those joint team working issues talked through. So I think that's my final slide. So thank you very much. Be happy to take any questions. If you put them in the chat question box, I will try and answer them whilst you're listening to the other excellent speakers, no doubt. Thank you very much.
Hi, Graham. Thank you for that. That was a really useful presentation. I just had a couple of questions for you while we're waiting for questions to come in the chat. So the first case with the Rasburicase and particular tumor lysis syndrome, is there any good practice that you've seen around the country that could have potentially avoided that case?
So this may become a patient safety alert. So we are working through whether it needs to actually be a patient safety alert, whether it meets our criteria. And as part of that, we'll be working up what the actions are. I think the availability issue is probably the biggest issue. It was PBR excluded medicine in the past, payment by result. So I think that may have had some issue with where it was kept, whether it was kept on wards or whether it was reserved because of the cost issue. It's now just in the tariff, so that I think may make that slightly easier. You know, it's about people making sure that they know when to give it, they know the criticality of it, and that they know it's available either in the emergency drug cupboard or on the ward where patients may end up.
Yeah. And do you think maybe education would have also played the part as well, if potentially?
I mean, education is obviously a key in any patient safety issues, but it's a fairly weak barrier to try and mitigate against them, because you teach somebody at once, those staff change, new staff come in. Much better to have those hard stops, those hard barriers, which I think the EPMA system or EPMA systems may be able to give us, whether that's not being able to prescribe a rituximab until you've put in a Hep B status, whether that's ensuring that if the Rasburicase is not given on time, the nurses are given a warning that this is a critical medicine, must be given within 2 hours or whatever. I think those are better measures than just trying to educate staff, especially when these drugs may be given on wards where they aren't experts. So like I said, we have seen where the chemo is given on a chemo day ward, the ward shuts at 5, those patients are then sent to a base ward wherever there's a bed, and now those nursing staff or medical staff aren't experts, so they don't really understand it. Now to teach all of them, I think, will be a big challenge. So the systems, I think, are a much better barrier than actually education in this instance.
Okay, that's great. Thank you for that. So I think with time permitting, I think we're going to move on to our next speaker. Thank you, Graham, again. And looking forward to seeing you in February for the next masterclass. The next speaker we have is Parmjot Kang, and she's the lead antimicrobial pharmacist at Royal Wolverhampton NHS Trust up in the West Midlands. This is her first time presenting, so I'm really looking forward to hearing her presentation on ePrescribing and using the ePrescribing system to support antimicrobial stewardship. So I'll hand over to Parmjot now.
Hello, can you hear me? Just checking you can hear me.
We can hear you.
That's great, thank you. Hello, so yes, over the next 15 minutes, I'll be talking to you about how our EPMA system supports us at RWT. Next slide, please. Next, yeah. So during the session, we will look at any limitations that were associated with paper charts, and then how ePrescribing affected those. So you can see the list of the reasons that we would like to work on there. I'll talk about our experiences and end on thoughts of what I think an ideal system would look like. Next slide, please. So you'll all be aware that in 2012, the Department of Health commissioned a study on how an improved IT system could actually improve health and social care. Kieran Hand and his team later carried out a survey of infectious diseases specialists on their thoughts of how ePrescribing could improve antimicrobial stewardship. And the survey interestingly highlighted that people were really interested in improving adherence to guidelines, improving the duration of antibiotics, so reducing them, ensuring allergies were taken into account and considered, and improving the appropriateness of the doses that were prescribed. And also they would like to have automatic interaction checks. So at RWT, we rolled out EPMA on one ward in March 2018. And since then, we've just continued to roll out across the trust. And then following that, the pandemic hit. So even though we're a few years down the line now, we still feel that we're quite new to EPMA, and it's very much a work in progress. And our list of things we'd like to improve and work on is growing all the time. So next slide, please. So I know this is an ePrescribing masterclass, and but when I see a paper chart, I look back at it in fondness because I used them for most of my career. And although EPMA has its advantages and benefits, some things were easier with paper charts, but we'll look at that as we move through. Next slide, please. So prior to rolling out EPMA, there was a lot of excitement about EPMA because we struggled with allergy boxes, although audits identified that we completed them in more than 95% of cases. But we had cases where an allergy was documented and the antibiotic that the patient was allergic to was still prescribed and given. So we were keen to stop this from happening. We struggled with documentation of the indication or the stock per review date, and audits showed that we were around about 50%. So we were at 50% with those standards. And when out-of-hours discussions were taking place about antibiotics, we had to rely on the information that was provided to us because we couldn't physically see the chart. And when point prevalence audits were carried out, it took the ward pharmacists a lot of time to complete the audits. And when we received the forms back, they weren't always complete because charts might not be available on the ward, the patient might be off the ward. So for a number of reasons, we weren't able to get the complete data for that ward. Next slide, please. So now we're using EPMA. Prescribing in some ways, so a prescription is similar to how it was on paper. So we still have all the key bits of information, but now particular fields are mandated. So you can't leave them off a chart. So you can't have blank boxes, for example. So the mandated fields in our EPMA system include the dose, the frequency, the route, and most importantly to the stewardship team, the indication. So that was great. And as you can see on there, we can choose to highlight certain messages to the prescribers. For example, we've highlighted there that this is a critical medicine. Next slide, please. So the 24-hour review. This is an option. So all antibiotics have this box where they are associated with a review that must be completed within 72 hours. But as you can see on that screen there, there's the option to not set a review. So some antibiotics are left without a review. So that's an issue that we're looking at. But the idea of this review is that within 72 hours, when the prescription is reviewed, it's documented on the system. And this is a really useful audit tool for us. So rather than going through a set of notes to see if a review took place, we can get that information from the system. But as I said, if it doesn't have a review, we're not going to get that information, so it's not foolproof. Next slide, please. So for every antibiotic, we put together a list of all the indications that it could be used for, and it was built from the information from the antimicrobial guidelines. But prescribers are still able to search the wider EMIS system to be able to select other indications that we actually didn't put together. So that's still an issue. And they still seem to be able to put in free text things as well. So I'm not sure how they are able to do that, but sometimes we're surprised by indications such as antibiotic as the indication or unwell. As you can see there, possible and probable is linked to some of the indications. We added that when we were participating in the ARC study, some of you may be aware of. So that really was useful there. And regularly we'll come across prescriptions where we're thinking, actually, we should add this indication to this antibiotic because although it's not listed in the guidelines, we feel that this is still a possibility and sometimes we will need this indication for this antibiotic to be prescribed for this indication. So we're updating the list all the time. Next slide, please. So we can skip over to the next one actually. So yes, so when you see a prescription chart, you'll see it looks like this. So there's a lot of scrolling involved. So the top of the chart will list, so the medicines are listed in order of date of prescribing. So as you can imagine, the antibiotics are going to be jumbled up somewhere within that chart. So you'll need to scroll down. But if you wanted to see what the patient was on antibiotic-wise before that prescription, you won't be able to see that on this prescription view. So with a few steps you can. So at the top, we select the discontinue option, the expired option, and under advanced filters, we have to select a view of those medications that are associated with a review. So remember, if the review has been deselected, we might not be able to view it, but otherwise we should be able to see as per the next screen. So if we do all those things, we can now see the antibiotics all grouped together, what they were on and what they're on now, and so that makes a lot of sense to us. So that's pretty similar to what we used to see on a paper chart, which was really useful, but unfortunately this is not readily available. So it's not available on the first chart we'll see for the patient, but we can get to this through a few extra steps. So I feel that's a limitation to when we're carrying out antimicrobial prescription reviews. Next slide, please. So this is actually the screen we work with for most of the time, because this is where we leave our notes, we review our patients, and scrolling through this screen is a lot easier because the list doesn't appear as long and the medications are listed here in alphabetical order, and we often communicate information about things for the pharmacist the next day to follow up, or any concerns we have about patients and their bloods. So as you can imagine, so that's already 2 screens that we're already looking at. So there's a lot of jumping between screens and scrolling, and I think that adds to screen fatigue. Whereas with a chart, you could open it up, or you might have 2 charts, but you could just glance through. If you saw the chart previously, you could immediately see any changes that were made, and it just seemed like it was an easier process visually screening as opposed to scrolling. And I found that when we were looking at a chart, I could recall and remember a lot more what's happening with the patient just from a quick glance at the chart. But with it being on ePrescribing, it's more difficult to remember because there seems to be a lot more information. So yeah, next slide, please. So yes, so we've linked to the guidelines, and if you can click to the next slide, please. So I would like to apologise for this slide. Our information systems department provides me every quarter with a list of patients for my point prevalence audit. So I provide them with a date and a time, and I request a list of all patients prescribed an antibiotic at that date and at that time. So basically I get a very big Excel workbook, which is divided into wards, and I've kind of broken down the top row into 3 sections, so you can just see the headings that I'm provided with. So we have patient details, the ward where they were when it was prescribed, the start date, who prescribed it, what for, which antibiotic it was, if there are any missed doses, and whether the review was completed, and if it wasn't completed within 72 hours, when it was completed. So this is really useful, but the problem with it is it also captures patients that I don't need within this audit, because if prescribers don't stop a prescription, complete it, it'll still keep appearing within the system. So often I'll get a really big list from information systems, and then I have to filter through and remove loads of patients because they're not, they weren't on antibiotics on that day. So that's a bit of extra work, which we're hoping to try and improve in the future. Next slide, please. So another way, if we were to carry out a ward-based audit, what we do is we can click on the red review dates tab and then select the ward that we want to look at, and then it will bring up a list of patients on medications that require a review. Again, if they select to not associate a review with the antibiotic, we'll miss them. But otherwise, generally, this will highlight some patients on the ward who need a review. And if you click onto the next screen, you can see the kind of list that comes up. So we get a list like this, and it's broken down into those prescriptions where the review is overdue. We'll get a list of those where a review is pending, imminent, due now, or one where they'll be reviewed in the future. But remember, sometimes past patients are within this system. If they aren't taken off and the prescription closed, they will continue to exist within this system. Next slide, please. Another way is to basically, there is the potential to create bespoke audits of real-time prescriptions, but these take a lot of time to create and to put together, and then even running off. So we're this is a work in progress. We're working on being able to set and create different reports where we can just run off in the morning and use whenever we want to carry out a specific audit. So this is something that hopefully we'll use more in the future. Next screen, please. So every quarter we present point prevalence audits to the IPCG. So the data we present now is very similar to what we used to present when we had paper charts. But now obviously the data is just handled by one person, and we don't miss any patients. So I think we're seeing more patients now using audits in this way. I would really have liked to have shown you a comparison of our data, so our point prevalence results before EPMA and after EPMA. But as I said, COVID has kind of skewed things for us. So our last point prevalence audit on paper was in 2017, and then the next one using EPMA was in the summer of 2020. So our data is very much skewed because of COVID. So, but generally, our antibiotic durations appear longer. The documentation of the indication is now 100%, whereas it was around 50 before. But the documentation of the stopper review date has fallen to around about 20% from 50. And I think that's because the review date box is an extra step that it's not mandatory, so it's often skipped by prescribers. So we are looking at how we can improve this. Next slide, please. So this slide we looked at earlier on. So going back to it, yes, the allergy box situation is a lot better. We're not seeing the data exist where penicillin is given to someone who has a documented penicillin allergy. And the indications are now documented, it's mandatory. We still struggle to make sure that the right indication is in that box, because you can always select something that's not appropriate. The stopper review date, as I said, because of the extra step, we're still struggling with. But the microbiologists, I think, were so amazed when they realized out of hours, you know, when they're talking to doctors about a patient and they're being told that a patient's on a certain antibiotic, but when they go into the prescription, they see that actually they're still on the previous antibiotic. And so they were able to really advise appropriately for that patient. We've had cases where doctors have called microbiology to say that vancomycin prescription is not very effective, but actually the doctors could quickly screen the prescription and see that doses were missed, and that was the reason for this. So as I said, point prevalence audits are easier, audits are generally easier, and although we now don't have missing treatment charts, sometimes we have, occasionally, there are situations where the whole system goes down, so there are no charts for anybody across the trust for a few hours at most. Next chart, next slide, please. So to summarize, paper versus ePrescribing, there's pros and cons for both. But with paper, I really miss just being able to visibly view a scan and just scan, the chart and be able to see what's going on. Where there seems to be loads of screens and clicks and steps with the EPMA system. So the whole reviewing the charts takes longer compared to when we had paper. But the benefits are obviously there. We can mandate fields. For governance, we can automate allergy and interaction checks. We're able to document reviews, and audits are a lot easier. But looking ahead, for the next slide, please, and the last slide, what do I see as our perfect system? Some of these we're working on now, and they will be possible, but I would like to maybe one day be able to prescribe based on the infection. So you go into EPMA and you type in UTI, and then you get a list of the antibiotics with the first line at the top moving down, so you can select work. So a bit like how our guidelines work. It'd be great. So we're working on dose banding. It would be great to be able to put in a weight into the prescription and get the correct dose calculated, and to mandate antibiotic levels within the system. Color coding or grouping the prescription view would be really great, so all the antibiotics are together, and possibly being able to authorize codes for restricted antibiotics. It'd be lovely to get alerts unnecessary prescriptions, and if a step dose is being given, to ensure that a regular dose isn't given within a certain time frame. And we're just hopeful that we can get easier extraction of real-time data via antibiotic alerts. And that's all for my presentation. Thank you for listening. Hope you found it interesting.
Hi, Pamjit. Thank you for your presentation. It was really insightful looking at the differences between paper and e-prescribing. And I have a couple of questions, and there's some questions in the chat. So whilst there are limitations with your current system, with the EMIS EPMA system, how do you think we can optimize it, and how much do you not think it's slightly better with having mandatory fields, having indications linked, compared to having your paper system?
It's definitely better, and I think for those of us who've worked with paper so long, change takes a while to get used to. I think that's part of the problem. So it's definitely an improvement, but I think the feeling was that it'd be a wonderful system where all of our problems would be solved, and so it's just a case of getting used to the things that we thought would be better that aren't. So we do so via the EPMA pharmacy team, we kind of feedback so they can communicate with EMIS about the things we like, but it feels like it takes a bit of time to get the feedback and to get things to start the process of enabling change. So some of the things I'd like to be changed are included on there, but it's just basically I think the number one priority would be audits. It would be really great if we could be able to have bespoke audits that we could pull and create and work on ourselves. I think that's where we struggle with. That's the main sticking point.
Okay, there's quite a few questions in the chat, and I'll go through them. And so one of them was, what EPMA system is this? And this is the EMIS EPMA system. The other question was in terms of your indication. So is indication mandatory for all antimicrobials, including topicals?
So it is mandatory for all systemic, not topicals. So it's actually, yeah, so we started off with antibiotics, and then we increased wider to antivirals and antifungals. But as I said, it's quite a new system, so it's very much a work in progress, and we're discovering new things and building on things and improving on things all the time.
Okay, another question was in regards to, because you indication is mandatory, and what happens if you don't know what the actual indication is? If you've got someone who's got, for instance, sepsis, and you don't know what the source is, what do you do then?
So we had, at the moment, the default seems to be as per cultures and sensitivities. And so we wanted to remove that as an indication, but we haven't actually done that. Before that, we had other options that were very vague. And so in that situation, the prescribers would just select anything, the closest thing. So that's a work in progress for the AMS team. So through the point prevalence, we're kind of being alerted to antibiotics where this is an issue for. So we go back and then we kind of try and add a line in that would cover that use to improve that.
Okay, and there's another question in terms of about your review date, and how do you ensure that the prescription just doesn't stop and isn't completely cut off once you get to your 48 hours or 72 hours of your review date?
So it's not a stop date, it's not a hard stop. So it's just a prompt. So even if, so the review date is just for them to acknowledge that, okay, we've reached a certain barrier, a certain point now, and we need to think about what we want to do with this antibiotic. And just clicking on the box that comes up will just enable us to be able to document and have evidence of a review taking place. So, but they could ignore that prompt and do nothing, and continue for as long as they want the antibiotic to continue. So we've thought about hard stops, especially when we were participating in the ARC study, but we haven't implemented it.
Okay. That's great. Thank you, Pamjit, for answering the questions. There are a few more questions in the chat, but we're going to move on to our final speakers. So we've got Nivi Ravindra from Royal Free London Hospital NHS Trust, as well as Marissa. So they're going to present on their EPMA system and how it supports their antimicrobial stewardship. Okay, so
great,
I'll hand over to both of you.
Just first of all, just want to say thank you to Steph and Sarah and to Anne for inviting us to talk to you today. We're really excited to kind of show off our e-prescribing system, and this is a Cerner system rather than the EMIS system that Pamjit uses. So next slide, please. So just wanted to give everyone a bit of a background about us and a bit about the Royal Free. I think in London especially we're a bit arrogant, assuming everyone knows everything about our trust, but Nivi, do you want to just introduce yourself and then I'll go into a bit of background of the Royal Free and ePrescribing. Next slide, please.
Yeah, hi everyone, my name's Nivi. I'm one of the EPMA pharmacists of the Royal Free. Prior to this, I was a rotational pharmacist at Barnet, which is also part of the trust. And then I moved into this post in August 2020.
So I'm Marisa, I'm a joint specialist pharmacist in infection and intensive care. I work at the Royal Free Hospital. I've been in my current role for about 10 years, and I've been involved in the development of our EPR system since 2015. Next slide, please. So the Royal Free London NHS Trust is a large teaching trust in North Central London. So we deliver care on about 15 different sites, but our 3 main inpatient sites are Barnet Hospital, which is a large DGH in the leafy suburbs of London. We have Chase Farm Hospital, that's also in the suburbs. That's an elective surgery centre, and it's one of the most digitally advanced sites in the UK. When it was opened in 2018, it was awarded HIM6 status, so we're all really proud of that. And then the Royal Free Hospital, so that's the original hospital in the trust, is a large teaching hospital. We have several specialist units, including solid organ transplant, infectious diseases, and we look after the regional renal services. Next slide, please. So I'm going to talk a little bit about e-prescribing at the Royal Free. Next slide, please. And like Pamjit, when we were writing this presentation, I was reflecting on why the antimicrobial stewardship team were kind of asked to be involved in the discussions around our implementation of CERNA so early on in the process. So we were asked in 2015, and actually it was about paper. So our paper drug chart had been updated following audits in 2014, where we looked at introducing mandatory indication and a mandatory review field. So you can see that on the screen now. So because of that work that we'd already embedded into the trust, I think we were then given a seat at the table very early on with regards to the e-prescribing, because we certainly showed that we'd improved our antibiotic prescribing by introducing those changes. So 2015, the first discussions started, and we went to several workshops to discuss how we were going to introduce good antimicrobial prescribing into the system. Lot of work later, so 3 years later, ePrescribing was finally launched at the Royal Free. So this was launched at our Barnet Hospital and Chase Farm sites in the first instance. And then I think it was 5 or 6 weeks ago, the Royal Free Hospital finally went live, and we are now completely e-prescribing trust. So that's been really interesting because I'm now working with the system that I've helped develop on a full-time basis. So it's been a bit of a hybrid up until then. Next slide, please. So we're going to talk to you how we've embedded some of those antimicrobial stewardship principles that we developed on paper into our EPR. So next slide, please. So the first one's a mandatory indication. So as a pharmacist, I don't feel that I can screen a prescription unless I know what it's for an antibiotic. So that was one of the things that we were really determined to have in our EPR system. So on paper, it was obviously a mandatory section, but paper you can't always have control of. But it was completed most of the time. Actually, it was pretty good. So we built a list of infections that we wanted to put into our system. So unlike the EMA system, the infection list is not related to any antibiotic. So the infection list is the same for any antibiotic. So we did a number of things. So the first list we built on the most popular infections. So the first thing that came out was respiratory tract infection, and the second was UTIs. We tried that to see whether that would be good in terms of picking the right antibiotic, the right indication for the antibiotic that had been prescribed. Actually, when we went back and audited, wasn't quite as well completed as we hoped it would be. So what we've done now is we've gone back and we have grouped them into indication by body system, and then we've used that to reflect our trust microguide list. So it's easier to navigate, and then the things, everything kind of meets up together. So you know, if you're going to respiratory infection, aspiration pneumonia is our the top one in the list, and it's the top one in the list for microguide as well. Next slide, please. Now, in terms of diagnostic certainty, this was something that we've only just introduced. So we took this as an opportunity in June when we were having a big update to our CERN system. We took our opportunity to add this into the system. So PalmJit has already mentioned about the ARC study. So for those of you who aren't aware, the ARC study basically classifies all antibiotic prescriptions as either possible, which is when an infection is not the most likely diagnosis, but you want to prescribe a prescription, you want to prescribe an antibiotic, or a probable infection. So it's likely that it is an infection, but the diagnosis and treatment is still needs to be reviewed because it's still not absolutely 100% certain. And then finalized, which means you're certain this is an infection and this is what we're going to go ahead and treat. So when we did this within the Royal Free, on paper, we found that our prescribing quality improved massively having used this system. And I know as the ARC study as a whole showed that as an improvement as well. So we wanted to take the opportunity to add that into our system. Now it is new, we haven't audited it yet, and I think there's still some work to be done in terms of education and training about the differences between possible and probable, but as something that we expect to be standard of care in the next few years, we thought we would take this opportunity to embed this into our system now. Next slide, please. Nivi?
Oh, yes. So another thing we've done to embed AMS into EPR is we've attached a default duration of 3 days to all our antibiotic prescriptions. So this is just for the systemic ones, not for like your topicals. This previously used to be 5 days. And in light of, feedback from AMS and working closely with Marissa, we as EPMA brought this down to 3 days, provided comms out to the trust. This was so that to prevent antibiotics from ever prescribed. And I'll move on to the next slide, please, where I'll talk about how we prevent this from falling off. So obviously, the 3 days, there's a risk that compared to a weekend, antibiotics inappropriately stopped. So in order to prevent that from happening, we have 2 phases of a review that fire in the system. So the first review fires at 24 hours after the prescription has been started, and it's what we call in standard terminology or EPMA terms a soft alert. A soft alert is one that can be dismissed. So it just fires to the clinical practitioner role, which is all our prescribers. So it doesn't fire to nurses and pharmacists in the first instance. It only fires if you're a doctor or a prescriber, because you log in with your smart card role as such. They have a specific role attached to prescribers. So at 24 hours, the first review fires and it says, do you want to review the antibiotic? Most of the time, we just find people dismiss it, but it's just a prompt to say, oh, hey, this antibiotic's been started. Then at 48 hours, which is obviously 24 hours before the actual antibiotic fall off, there's what we call a hard alert that comes into the system, which will look like what you see the screenshot on the system where it says over 48 hours has passed since co-amoxiclav has started and anti-infective review must now be completed. As you can see, there is no option to dismiss this or press OK. All they can do is press review, and that's why it's known as a hard alert. So i.e. when that fires, they have to do something about it. And this is obviously embed good AMS practice. If they don't, and also at the point of initially prescribing, I know I've said 3 days default, but at the point of prescribing, a alert fires to the prescriber to say, please note this is a default duration of 3 days. Are you sure you want to proceed? If not, it will allow them to modify the prescription and increase the duration, because there might be at a time where you need 7 days of an antibiotic and you don't want it to follow the 3 days. Likewise, if you're coming up to a weekend, we wanted that flexibility to give prescribers the option to prescribe for multiple days, covering a bank holiday period or a weekend period without it falling off. So there is an alert that fires at the point of prescribing as well to allow flexibility to amend the prescription. So it's not always fixed at 3 days, it's just a default. I'd like to stress that. So can I go to the next slide, please? Thank you. So this is what the review form looks like. So once they hit that review button on that alert, it takes them into this window. And there's multiple sections. So if you've got on multiple antibiotics, there's options for think about 4 or 5 antibiotics in this form. So you can do multiple reviews in one go. They'd simply type in the name of the anti-infective, and then from the action drop-down menu, I think if you go to the next slide for me, it'll show you the options for these actions. Next slide, please. Yeah, perfect. So you can see the actions, the first screenshot for the actions. It says you can stop the anti-infective, switch it, continue for a longer duration, or it's for long-term prophylaxis. So you have those options there. And then depending on what action you select, there's other fields that become mandatory, like a reason. If you say you're going to switch, a switch reason becomes mandatory. If you say you're going to continue the IV, IV continue reason becomes mandatory. So there's all what we call conditional logic in this particular power form, which allows certain fields to open out and become yellow or mandatory in light of selecting a previous option. So that's kind of one benefit from an EPMA system as such. Can we move to the next slide, please? Perfect. So concomitantly, while the doctor gets that particular review I've just spoken about, the pharmacist also gets something in the system. They get tasks firing to them. So we have something called a pharmacy care organizer, which is where pharmacists pick up all their daily tasks. And within that, 24 hours before an anti-infective is due to stop, a task will fire to kind of be a trigger point to the pharmacist to prompt the doctor maybe to review if they haven't completed the review already. Secondly, a second task will fire once an anti-infective actually stops in the system, a second task will fire. And this again is to allow pharmacists to know that something stopped and quickly intervene, hopefully, if it has been stopped inappropriately, or review it to see that it has been stopped appropriately. So we have a lot of mechanisms in the system to help both the prescriber and the doctor, and the pharmacist, sorry. Next slide, please. So moving away from antibiotics, now we're looking at gentamicin calculator. So we're one of the few trusts, I don't know if there are any actually other trusts who actually have this gentamicin calculator. We bespokely built it for our Cerner system. So other Cerner clients don't have this as such. So it's not model content as they call it. It actually got nominated for a National Patient Safety Award. So we're very, very proud of it. And I'd like to sell it in this meeting if possible. So what it does is upon prescribing gentamicin, it forces you to document the height and weight. And then takes you into that window that you see at the bottom, the second screenshot, where you put a height, weight, and that will give you a creatinine clearance if there's a recent creatinine in the system. And using that, you have to answer whether the patient's severely renally impaired or not. So that's and based on whether you say yes or no to that, this calculator will take a lower dose and work it out accordingly. So if you move to the next slide for me, please. So the gentamicin calculator, once you've satisfied those parameters, you tick the option that you need. So whether it's a treatment dose, whether it's for catheter change prophylaxis, whether it's for pre-op prophylaxis, or whether it's for endocarditis. And the calculator will take the requisite mg per kg and work out accordingly. And like I said, if they're renally impaired and you take renal impairment to the previous answer, it will give you the 2.5 mg per kg rather than the 7 mg per kg traditionally. And once you tick that and press OK, it will give you a suggested dose, and then the prescriber is expected to just eyeball that and make sure that looks appropriate. We know if you've answered the previous parameters correctly, we know this is correct because we spend a lot of time. I spent, I think, almost 2 days trying to break the calculator with all these extremes of body masses. So we know it works really well and it's foolproof. Otherwise, we wouldn't have allowed it to go live as such. And another added benefit of this gentamicin calculator is that it fixes a 1-dose duration onto the gent. This is to stop gent being overprescribed. So you can see in the prescription, which is the bottom right-hand corner, for gentamicin 440 mg, the frequency is every 24 hours. That's our default starting frequency, but that can be amended before signing the order off. The prescriber has flexibility to amend that duration. But the key point here is the duration is 1 dose to stop overprescribing of gent and stop those instances where you might get 2-3 doses of gent being given at a weekend. That is amendable. So say you've taken levels and you know the patient's stable and gent, you can amend that duration of 1 dose to 2 or 3 doses if that's appropriate for your patient. But yeah, so that in essence, I know is really quick, and time, I could speak about the gen calculator for hours, but time permitting, I'm going to stop there. So thank you, and I'm happy to answer any questions you may have on any of that.
Thank you, Nivi and Marissa, for that presentation. It was really, really insightful, and you've got quite a sophisticated system with the Cerner system. And yeah, I've got Kieran Hand, and as many of you know, Dr. Kieran Hand is the lead for optimization and prescribing for AMR workstream in NHS England and NHS Improvement. And I think he's got probably a couple of questions to ask you as well.
Thank you, Steph. I'm extremely grateful to Ann Slee and to Steph for allowing us to take over the webinar this month, but more importantly, much more grateful to the presenters, to Parmjit, who this is her first time presenting. I'm sure you'll all agree that she's done a tremendous job, and I'm really grateful to Parmjit for sharing the functionality of the EMIS system, and then also to Marissa and Nivi for a fantastic presentation showing the capabilities of the Cerner system, but also the work that they've done to shape those capabilities and functionalities. And this presentation is just 2 systems, but it really fills me with hope for the future that we're just about to embark upon this journey in prescribing in hospitals, where we're going to move from it just capturing prescriptions to influencing prescribing and improving the quality of prescribing. I don't want to take up all the remaining time. I've got lots of questions, which I'll probably pick up with Marissa and Parmjit and Nivi offline. But thank you all again for really impressive presentations, and I hope we can commandeer this webinar again in the future, and maybe even have a whole day workshop on showcasing EPMA. And the next step, of course, is capturing outcome data. Can we demonstrate that this amazing functionality is safely reducing prescribing? Thank you again.
That's great. Thank you, Karen, for closing. There's just a couple of things, just an observation from all our speakers that we've had today, from Graham to Nivi to Marissa to Parmjit, just showing that how patient safety it really needs to be embedded with EPMA, but also antimicrobial stewardship, and that's demonstrated by all the 3 presentations that we've had. And one final question I have for all of you: do you think there needs to be a national list of indications? Is there one for antimicrobials? Do you think there needs to be one, or is there one in the works?
I can respond to that if that's okay, but there is
yes,
there is one in the works. But I will be reaching out to existing systems and asking them for their short list of indications, and we'll hopefully be able to provide software developers with a single list and a concise list that people can use.
And does anybody have any final comments before we round off? Yes.
Steph, is it okay? Can I just say, good relationship building is imperative if you want to get antimicrobial stewardship built into your EPMA system. So if you're a bit not quite as far down the line as we are, please do make sure that you're given a seat at that table. It's really, really important, so that you can embed these systems into your e-prescribing.
I think that's an excellent point about being there very early on rather than being late and then adding things on. It's really important to have collaboration between all teams. So that brings us to the end of this month's masterclass. Thank you to everyone who's participated. So the next masterclass is on Wednesday, 15th of December. There'll be some information that will follow shortly. If you would like to present, and I'm very welcome for any volunteers, please could you email Sarah Black at the AHSN, and the email's on the screen. And also please join our Medicines Optimization Digital Learning Network on NHS Futures. I look forward to seeing all of you again next month. And yes, please, by all means, I'm looking for any volunteers, anybody who wants to come and join, please join. Okay, thank you everyone. Okay, we'll see you next month.
Thank you.
And well done to you, Steph.